So now
Yes.
I will have my talk to the topic to introduce how to deal with patient with cardiorenal metabolic in early stage. And I think Professor Wu and Professor Du have explained and introduced many novel idea and information. So I will be focused on the treatment and some evidence-based data. Now we know the CKD is a very severe problem and is also a disease burden of our growth. And we know the major problem, just as the professor will say, how to screen. From the revealed CKD data, we know most CKD stage 3 is usually the golden stage to treatment and to diagnose. But it's up to 97% CKD3 patients were undiagnosed, even with some comorbidity, with cardiovascular disease, with hypertension, with type 2 DN. But we also can see in the many countries, even like very advanced country, they have many undiagnosed CKD3 patients. So even we have many evidence-based medication like SGLT2, like non-steroid MRA, and even semaglutide, the new and new evidence-based yesterday, the novel GLP-1. If we have know the patient where we cannot target there. So it's the slide from last year in Thailand, the ICE, and how to screen the high-risk patient, because it is impossible to screen AV patient. So we can screen like OH patient and some ways, even in Asian, in Taiwan, in China, in Singapore. I think CKD is a severe and a major problem. We can check renal function in some autoimmune disease like SLE in some young and female patients. And the pandemic viral disease not include HIV and also COVID-19 and hepatitis B, hepatitis C are very frequent associated with renal disease. And usually we will take history with family member. So if they have some CKD or even ESRD, we will pay more attention to that. And we know some genetic risk factor such as the ADPKD, we will follow the patient and we have some new medication to treat these patients. And I think even in advanced, highly developed country, we also have some patient with low socioeconomic status. So how to pay more attention to that? And in some country like Singapore, like Southern Taiwan, we have recent publication of the Southern Taiwan when one more degree Celsius increase, then we have more acute kidney injury and more CKD patient. So now under the global problem, the degree is higher and higher. We should let patient to encourage water intake and avoid more sunshine, maybe in sun like time. And if the patient got prior acute kidney injury, they will have higher possibility to develop AKD and even CKD. And the high risk preeclampsia and the nephrotoxic agent. And I think the obesity is a global problem. During past 2 years, many patients pursue the treatment of GLP-1, not only DM patient, we also have many colleagues or many relatives, they just buy like GLP-1 to decrease their body weight. So the obesity, I think, is a global problem. Even in ADA, in ESD, we can know many clinical trials, like such as tirzepatide, they treat the very obese patients. This is the category, the triangle, so we can see all the new or novel or evidence-based medication over the table. But no matter what medication develop, I think the lifestyle is the very important investment to explain and to educate our patient. If the patient didn't have good diet control, exercise, quit smoking, and weight reduction, even they took all the 4 medication, the 4 pillar, I think the outcome still maybe not very good. So we know the exercise, the diet, and the cessation of smoking. We have some nurse or some education team to introduce how to do rising. And I think in CKD patient, the hyperkalemia is a very important and a very dangerous thing. Especially we know the RAS inhibitor and the MRA will increase the risk of hyperkalemia. So how to deal with the hyperkalemia? The first line is correctable some factor, like optimize serum bicarbonate level and optimize glycemic control. And we know SGLT2 have some evidence to decrease the hyperkalemia even combined with MRA use. And the second line, we will do some diet restriction. We let the patient know what fruit, what vegetable or soup or juice, how many, what kind of food they have some potassium content, and to avoid too much potassium intake. And the third line is to adjust medication, such as a RAS inhibitor, MRA, and we have some other medication. They will maybe increase the hyperkalemia. And the last step, even in the outpatient department, some patients, they say they have good diet control, they have good sugar control, but they still sometimes have hyperkalemia. So at that time, we will give some extract racing to decrease the hyperkalemia, like a cassate or kalimate use. This is my patient. It's about 1 year ago. This 58-year-old woman, she is hospitalized for acute and chronic kidney injury, and during the admission because of hyperkalemia. So we give some Calumet to treat the hyperkalemia. And just 6 days after hospitalization, she developed severe bloody stool. And we arrange colonoscope, and we can see the colon ulceration. And from the pathology, we can see the drug crystal of Calumet. So it's a very severe and high mortality problem of the traditional Calumet medication use, and it's published in AJN. We know the problem is severe, also is rare. The mortality rate is up to 20.2%, and mostly we depend on pathology diagnosis. It should be presented with drug crystal, and the most found at colon or rectum. And the second part, we know the first-line drug therapy. I think including SGLT2 inhibitor and RAS inhibitor are very important and necessary medication to treat our patient. And the non-steroid MRA and the GLP-1 also have more and more evidence. It's also our publication last year from JAMA Network Open. We compare SGLT2 with DPP4 inhibitor in Taiwan to compare the cardiovascular outcome and the kidney outcome. And we can see from the statistic calculation, SGLT2 is better than DPP4 no matter CV and the renal protection effect. And we know regardless the sub-analysis of age, gender, comorbidity, and background medication, the SGLT2 is better than the DPP4 inhibitor. And from another publication of JAMA, we know that from the enhanced database in USA, the SGLT2 also have better evidence base than the DPP4, including the mass and including the hospitalization for heart failure. Even in acute kidney injury, we also can see the SGLT2 have better protection effect than the DPP4 inhibitor. But a very concern and a serious complication of SGLT2, we call the diabetic ketoacidosis, or namely EUDK, euglycemic decay. We can know from the figure, especially when the sugar is poor control, the euglycemic decay is much more in SGLT2 than in DPP4. And we know from previous SGLT2 publication, even DAPA, Emperor, or DAPA CKD, the SGLT2 have effect of eGFR dipping, but mostly the dipping is benign and reversible. And in the long term of the publication, they all have the good renal protection effect. We know the mPAR is act over the proximal tubule and is block the sodium and the glucose absorption. So the sodium will go to the macula densa and will induce the TGF feedback and will decrease the intraglomerular pressure and the blood flow. So result in long-term better effect. How to deal with the eGFR dipping? Is the dipping severe, or we can just neglect it? From the Taiwan Chang'an Hospital's research from Professor Zhang Yixing, we can see from the more than 10,000 patients, mostly patients will have eGFR dipping. About 1/3 non-dipping, and 1/3 a little dipping, and 1/3 have 10 to 30% dipping, and just less than 4% have eGFR decline dipping will more than 30%. And from the analysis, we can see if the eGFR dipping or decline more than 30%, maybe we'll have poor composite renal outcome. So the 30% is second by category to adjust RAS inhibitor. And so far, we also use 30% to use the clear cut level to use or hold SGLT2 medication. From the analysis, we can see what is the risk factor the patient will develop decline more than 30% dipping, like use other diuretics, even saline, even MRA, even loop diuretics, or poor sugar control, depend on insulin use, or have more comorbidity like stroke. They will have higher possibility of eGFR dipping more than 30%. And from national health insurance data in Taiwan, we know SGLT2 except just a little population will have eGFR decline. Mostly the SGLT2 will protect renal function and will result in less acute kidney injury. So it's good for kidney. So we can see from the KDIGO, they say the reversible decrease in eGFR on initiation is generally not an indication to discontinue therapy. And the reduced GFR result from SGLT2 can result in a dip in eGFR, and which is usually and the most reversible. And none of the large trial demonstrate an increased risk of acute kidney injury. So now we move to the first case of my patient. This is Mr. Lin, and he is 74 years old, and is a retired man. And this is not my outpatient department patient before. He's followed up at a cardiovascular department, and we can see his DM duration is 14 years, and relatively good sugar control, and the eGFR is 16, and the UACR is 178, and a good blood pressure and the lipid control. So in the cardiovascular patient department, he have the hypertension, dyslipidemia, UACR, and the retinopathy. So his medication for the diabetes include metformin, include some SGLT2 inhibitor, and the suburea. We can see the risk category. He's over the A2 and the G2. The story is developed last year about October because Tainan City developed a pandemic dengue fever. So more than 20,000 citizens got dengue fever at that time. So this patient got dengue fever and he got sick and got dehydrated and very poor appetite. So almost bedridden at home and get total resting. And 1 week later, his family found him conscious disturbance and very weak. So sent him to our emergency department. We can see at our emergency department, his sugar is not very high. His A1C is okay, but his eGFR is from 60 dropped to just 5. And we can see some hypotension, high liver function, and very acidosis with ketone positive. So he is arranged admission for dengue fever and acute chronic kidney disease and diagnosis of euglycemic DKA. So we hold the medication of the SGLT2 inhibitor. From the flowchart, we can see if we use SGLT2 over our patient, we must follow up to see the creatine or eGFR have 30% change. If the patient has 30% above change, we should assessment the foreign status and the acidosis. So we should pay attention to 2 problems. One is euglycemic DKA, and another one is over diuretic use. And after discharge, the patient, the renal function returned to almost even a little better than baseline. So the patient didn't return to his cardiovascular department outpatient and transfer to my outpatient department. And I re-challenge Jardins to this patient. And we can see the eGFR so far almost 5 months is very stable in this patient. So we know the critical remind us the 6-day rule. What is 6-day rule? We know that when the patient got sick, maybe they will got dehydration or hemodynamic or acute kidney injury. So we should discontinue some medication such as metformin, RAS inhibitor, and SGLT2. And if the patient will have major operation, or the medication should be discontinued 2 or 3 days before the operation. Mostly, we know to discontinue the medication during admission, but sometimes maybe we will forget to resume the medication after his discharge. So I think it's a very important thing to recover and resume the pill when his hemodynamic is very stable to protect his heart and the kidney. And not only RAS inhibitor, there's a turn the sediment such as sulfonylurea, diuretics, and the NSAID, the medication should be discontinued or should be paid more attention to use or not to use. Now we have 4 SGLT2, and if you use Carna, DAPA, and MPA glyphosate, they just need 3 days before operation to discontinue. But if you use ER2 glyphosate, because he have more longer half-life, so should be paused 4 days before operation. And the critical and the FDA tell us to resume SGLT2 inhibitor after the patient's intake, after his condition back to baseline. And it's a paper from Diabetes Care. We know the SGLT2 will increase the glucagon secretion, and we know the DLV4 inhibitor will decrease the glucagon secretion. So some study told us to combine SGLT2 and the DLV4, maybe will decrease the glucagon loading and decrease the effect of euglycemic DKA. And this is my second patient. Is Mr. Shen, a 39-year-old officer. He just have diagnosed of DM for 2 years and transfer from GI outpatient department to my clinics. And at my clinics, his HbA1c is 71%, but he have very poor renal function. eGFR is 41, and the UACR is more than 2,000, and have good blood pressure and the lipid profile. So I arrange renal biopsy to this patient because we know typically the diabetic nephropathy will have proteinuria over maybe 3 to 5 and even 10 years. And usually the patient will have retinopathy and have some evidence of diabetic nephropathy or nephrotic syndrome. Because the patient just have 2 years of diabetes and he didn't have any retinopathy or triopathy. So we suggest and we suspect his proteinuria is due to other problem. So after renal biopsy, we diagnose the GNFSGS and we give the steroid to treat. So this patient, he's at A3 and G3B is very high risk to develop ESRD. This patient is diagnosed GI problem and follow up at the GI department for almost 2 years. But we can see his eGFR from the GI department is very poor, from 55, and when transferred to my outpatient department, it's just around 40. So I arranged renal biopsy, and after the diagnosis, I give him a steroid. And the eGFR transient improved, but then down. So I give the Jardiance from the 2021 until now. So after the Jardiance use during past 3 to 4 years, his eGFR is very stable at 41. And we can see his urine protein, when I arrange renal biopsy, his urine protein is very high. And after steroid use, the proteinuria transient improved, but then rebound. So when I give the Jardiance, his proteinuria now is relative under control. From the MPAR clinic, we know more than half patients didn't have diabetes and have other like GN, hypertension, or other etiology of renal disease. And from the sub-analysis, we know no matter is diabetic kidney disease or GN or other etiology, the guardians all have renal protection to this patient. And no matter his eGFR and no matter his UACR, all of the protection effect. Okay, it's my final patient. It's Mr. Wang. He's a young guy, just 31-year-old, and we know the Taiwan have very good chip engineer, and he's an engineer at Tainan. But maybe he's too busy to control his diet and very high pressure. So we can know he have diabetes for 5 years, and the HbA1c 10.1, and his eGFR is 51, USCR is 560, and he is more than 100 kilogram. I ever told him many times to exercise and for body weight reduction, but it's very difficult for him to do that. And he's transferred from cardiovascular department to my outpatient department. And we can see just a 31 young guy have hypertension, dyslipidemia, and heavy proteinuria, and very obesity, and he even have gout. So for the diabetes control, he used suburea, TDD, GLP-1, and insulin he refused because he is very needle. He has needle phobia. So even GLP-1 just once weekly. I try my best to educate and to let him accept the injection at least 6 months. And he cannot inject by himself. So it's go to his company, and the company have a nurse. So every Wednesday, the nurse will inject the GLP-1 for him. So I think it's very poor control. Yeah, we can see it's A3, G3A, so it's very high risk to develop ESRD. Okay, it's about 7 years ago. First time he find his CKD due to he got hypertension crisis. You can see the eGFR dropped to almost just 30. So he then follow up at the cardiovascular outpatient, and then because his renal function just around 50, so he's transferred to my outpatient department. And I tried to control his sugar, use GLP-1, use TDD, use metformin, but he refused insulin. Then from 4 years ago, I used Jardiance because Taiwan cannot copay the GLP-1 and the HOT2. So he have self-pay Jardiance. And so far, his eGFR from the Jardiance use is 51. And to last month, he went back to my outpatient department is 61. I think it's relatively stable. And you can see the hypertension crisis, his urine protein rise very high and then down. And then when one time his sugar got very poor control is during COVID-19 pandemic period. And he disappeared from my outpatient department for about 6 months. And when he returned, he's very poor HbA1c. So use this medication. And so far his proteinuria is just okay and around 420. Okay, it's our team's publication last year. Before the publication of semaglutide, and we believe GLP-1 have some good renal effect to our patient. So we use this study design to compare the GLP-1 and the basal insulin in the diabetes poor CKD control patient in Taiwan. And we found that the GLP-1 analog have better renal effect than the long-acting insulin for the kidney protection. It's published about last July. And we know yesterday is a very exciting study of semaglutide, the first study, just as Professor Wu have said. It's agent. We can see all the mortality, primary outcome have very novel and very fantastic power. And we also have a spy at Stockholm and catch our Professor Wu. So I think it's very interesting and very novelty. And finally, I will share later from the W Kidney Day committee. I'm the chief editor of Taiwan's ACA Nephrology now, and we released the medication. We received this letter last month from the WKD. They have an article. The name is "Mind the Gap in Kidney Care." Translating what we know into what we do. This published in Kidney International about 3 months ago. And the WKD hope the article can be introduced to other countries, including Taiwan and other 5 journals worldwide, to let more patients and even doctor and even staff to know how to shrinkage or how to treat the gap. And this article will publish also in ATA Nephrologica next month. And I very brief introduce the table of this article. He mentioned about most in the earth, globally, the unawareness of CKD is a major problem. It's about 80 to 93%. And even the 20%, less than 20% patient, they are aware of CKD, but proteinuria monitor just half. Blood pressure just 40% to go, HbA1c just 60% to go. RAS inhibitor use about 17% is the best item. And we talk so many for the SGLT2 inhibitor use. They monitor to use SGLT2 more than 3 months, just 5% globally. And how many patients can do very good diet control exercise? About 20%. So even we discuss so much, but I think many countries have many problems and many issues, even socio-economic, health system, policy, and the global problem to let many patients cannot use or even know the novelty and the evidence base of SGLT2. Of course, I believe in Singapore and in Taiwan, we believe we do much better than the global average. But in the global area, how can we to do our best and to help other country or other patient? I think is very important issue. And finally, I think the SGLT2 now is first line, and we also know the non-steroidal MRA, GLP-1, and other novel medication. They are very costly, and I think the combined use about the effect, safety, maybe we need more randomized control trial. But at this point, I think the novel and the importance of SGLT2 is very high. And thank you for everyone's attention. Thank you.
I appreciate the invitation to be here today, a topic which is very dear to the hearts of nephrologists. And the topic given to me is managing difficult patients with cardiorenal metabolic syndromes and what's the treatment objective in different disease stages. So as Dr. To has kindly put it together, it has to be done in a coordinated manner, hence the word cardiorenal metabolics, or cardiologists, nephrologists, and endocrinologists, and not to forget our primary care physicians who are at the forefront of our early chronic kidney disease stages 1 and 2. So what I will be doing today is my talk will touch on epidemiology and the burden of chronic kidney disease. Then I'll talk about chronic kidney disease diagnosis to care models, and finally some cases to finish my talk. As far as the epidemiology is concerned, we are aware that there are multiple risk factors which contribute to chronic kidney disease and also vice versa. And we know that hypertension globally is the #1 cause of chronic kidney disease, followed very closely with diabetes. From a Singapore perspective, diabetes leads it. So 2/3 of patients who have chronic kidney disease in Singapore are due to diabetes, with hypertension being hand in hand. So none of these things exist on their own. They are very much associated with cardiovascular disease, hyperlipidemia, elderly age, population is aging. Certain family history risk factors, of course, contribute. Obesity is one, and certain lifestyle habits like tobacco usage. If you look at the increased risk of cardiovascular events and deaths, we see that it is a combination of having the underlying diseases that are causing chronic kidney disease. So if you see the black bars here, they are without diabetes and chronic kidney disease as a baseline in general population. You add on diabetes, which are the pink bars, and your risk of heart failure, acute MI, cardiovascular events, and TIAs, strokes, peripheral vascular disease, and death goes higher. Chronic kidney disease is even higher than diabetes mellitus alone. And you combine diabetes and chronic kidney disease, and all of these risk factors become multifold. So these are the usual cases that we're dealing in our practices, where diabetes alone may not be there, but chronic kidney disease may be there, and combined, definitely our patients are at much higher risk of cardiovascular events and death. If you look at albuminuria and eGFR, so from the primary care perspective, eGFR has been something that everyone has been looking at. We have all been checking serum creatinines for the longer time. But as the guidelines have shown, albuminuria is an independent risk factor for both kidney events and cardiovascular death. So we have to, on a screening perspective and also prognosticating perspective for the risk factors, and then look at both the estimated GFR and the urine ACR, which both have their value in looking at the prognostic risk factors and also the management of these diseases and how we are assessing our treatments. If you look at type 2 diabetic patients, chronic kidney disease and heart failure are the most frequent first cardiorenal disease manifestations. So this slide illustrates that a lot of these patients had manifestation of chronic kidney disease in patients who were type 2 diabetic, heart failure followed second, then stroke, acute MI, and peripheral arterial disease. So as I mentioned, this continuum of cardiorenal metabolic disease has to be handled holistically and comprehensively with a shared strategy and a combined approach with all the specialties. Not only is chronic kidney disease promoting or contributing to all of these comorbidities, it is significantly increasing the morbidity and the high inpatient care needs. So if you look at patients who have progressive amount of chronic kidney disease, the risk factors for them getting hospitalized and the incidence of them getting hospitalized goes much higher. So when we reach stages CKD stage 4 and 5, which is end-stage renal disease, these patients are essentially attached to the hospital with multiple admissions per year, not only contributing to the burden on the healthcare system, but also on the quality of life of these patients and causing a caregiver burden and stress. This problem is not unique to any specific region or in the world, but in the context of South Asia, I have highlighted some of the countries here. Singapore is at 13.8%, and Taiwan is at 7.4% for the prevalence of chronic kidney disease. Some of my colleagues have done studies in Singapore, and we estimate that by year 2035, a quarter of Singaporeans will have either risk factors or evident chronic kidney disease, which is a very, very high burden. And we are number one in the world for diabetes-induced chronic kidney disease. So it is not something to be taken trivially, and the numbers are exponentially increasing in our country, especially in Singapore. So how do we, with this knowledge of it being a major health system crisis and with increasing loads, how do we diagnose chronic kidney disease, and how do they lead to an effective care model to be able to cater to the needs of the population? So CKD is a global burden. There are certain at-risk individuals in population, especially those suffering from hypertension, diabetes, or known cardiovascular disease. But in many cases, our demographics, older population, certain ethnicities. So for example, in Singapore, the Malay community is especially prone to having these cardiorenal metabolic diseases and chronic kidney diseases, accounting for about 40% of end-stage kidney disease cases, while being 15% represented in the demography of Singapore. So certainly a high-risk population. And then, of course, certain environmental exposures and if they have family members who have chronic kidney disease. So screening and early diagnosis of chronic kidney disease becomes very important. And as I mentioned, it is an approach based on two pillars, with a blood test with serum creatinine, and of course calculating the estimated GFR, but also something which may be overlooked, and that is a urine albumin to creatinine ratio. So that brings me to the KDIGO heat map. And as the nephrology community is well aware, KDIGO is a bread and butter guidelines for nephrologists all over the world. And as you can see here, I would like to highlight that many times cases are referred to nephrologists when the eGFR drops below 60. But if you see on the first row, when the eGFR is almost normal and it is above 90, and if you have albuminuria at this stage with a normal GFR, you are still in the high risk category, which is shown in the orange upper right corner square. And the risk for progression of chronic kidney disease and the other associated risks are as high if you would have a patient whose estimated GFR may be as low as 30 with minimal to no albuminuria. So I think this heat map illustrates very well where not only do you need an estimated GFR to look at their risk prognosis and risk progression, but also albumin becomes an independent risk factor for looking at their chronic kidney disease progression and associated risk of all-cause mortality and cardiovascular related incidences. So once again, the key take-home messages all the way from our primary care colleagues to our associated specialties is that albuminuria is very, very important in prognosticating and managing these patients. So with this approach in mind, early CKD management starts in primary care. Only when patients are below an estimated GFR of 60 do usually nephrologists get involved, and we usually call it firefighting at that point, because you're dealing with complications of chronic kidney disease and trying to make them stay off of dialysis. So the work essentially starts when they have a normal creatinine with some albuminuria in the primary care setting, or they have an estimated GFR above 60, and that is where lifestyle modification, blood pressure control, glycemic control, lipid control, and most importantly, and what I'll show later on in the guidelines, is albuminuria control. Then, of course, the secondary care comes with nephrologists for their CKD complications, and then a multidisciplinary care when they are ending up on dialysis to look at their various accesses for dialysis with a vascular surgeon, psychosocial support with the social workers, and so forth. So with this in mind, I would like to share a real-world study which was done by my colleagues in Khoo Teck Puat Hospital in Singapore. And in this study, they had type 2 diabetic patients with diabetic kidney disease, a very healthy number of 4,400 over patients, and they were randomized to either without an SGLT2 group or with an SGLT2 group with standard of care, which included optimal RAS inhibition. 3 kinds of SGLT2 inhibitors were used, empagliflozin, dapagliflozin, and canagliflozin, and the primary outcomes were chronic kidney disease progression of more than 25%, and certain or ending up on dialysis. And the mean age that the patients were on were about 60 years old. They were mostly on ARBs, a significant amount of diuretics. So these are the kind of populations that we are usually dealing with in the public sector when we see these patients with multiple comorbidities. And the hemoglobin A1Cs at baseline were around the 8 to 8.8 range. We found that patients who were younger and who were counseled on the effects of being on SGLT2 inhibitors for a longer period of time, which would delay their dialysis, they tended to be more compliant and more open to receiving SGLT2 compared to the older patients who were nearer to their dialysis, to their journey to dialysis. And we found that chronic kidney disease progression was reduced by 40% when patients were put on SGLT2 inhibitors, and there was a reduction in about 67% for them to develop dialysis. This is quite in line with the global trials that we have seen for SGLT2 inhibitors, and it was quite reassuring to see this real-world evidence play out with SGLT2 usage in Singapore. And we found that this was independent on their initial GFR that these patients were started on. So if their GFR was above 45, or if their eGFR was less than 45, which is CKD stage 3B and worse, the rate of CKD progression and development of end-stage renal disease was still there, regardless of their baseline eGFR. So the message that we got from this was that it is never too late to start these patients on SGLT2 inhibitors. Of course, the earlier the better, but even if they reach CKD stage 3B and worse, it is still effective for them to go on SGLT2 inhibitors to reduce the progression of chronic kidney disease and reduce their incidence of end-stage kidney disease. Also, there was a question raised in the study on their baseline level of albumin to creatinine ratio, or albuminuria. So we had patients in the mild range, the moderate range, and the heavy albuminuria range. And as you can see by the p-values, the reduction of CKD progression was across all these three albuminuria categories, once again pointing to the fact that even if our patients have very mild albuminuria, they are still candidates for SGLT2 inhibition, which will reduce their risk factors for CKD progression. Granted, there is a class effect in SGLT2 with all three major SGLT2 inhibitors, but one thing to highlight in the real-world evidence was that empagliflozin had much larger amounts of relative risk reduction and better p-values or clinical significance compared to some of the other brands that were used in our public sector, and for this reason, empagliflozin now is on the standard drug list and very much subsidized for our patients. So I apologize, I'm actually in a hotel lobby, so there's some music playing. I'm just going to mute it. Just a minute, please. Sorry about that. So this slide basically shows that, again, empagliflozin had the most significant effect on CKD progression, irrespective of the GFR categories as well. So it gives a very good message to our primary care colleagues who will see patients who are above usually GFRs of 45 to be able to initiate empagliflozin or canagliflozin earlier on in the patient's journey in the cardiorenal metabolic disease management to reduce the progression of chronic kidney disease, and that brings the maximum amount of benefit to these patients. I would like to illustrate some of these things with two or three cases that I've chosen. So the first case is of a lady who's 68 years old, Chinese ethnicity. She has type 2 diabetes, chronic kidney disease stage 3, chronic heart failure, and ischemic heart disease. She had a blood pressure of 135/85, heart rate was normal, some trace pedal edema, lungs were clear, a GFR was 55, so CKD stage 3A, and a urine ACR of 45, which is in the moderate albuminuria range. She was on valsartan, so on RAS inhibition, amlodipine, and glipizide. So if we look at this case, blood pressure can definitely be better controlled. There is some trace pedal edema, so perhaps indication of underlying heart failure, and definitely has a chronic kidney disease stage 3B with adequate amounts, or at least around the 50% percentile dosage of RAS inhibition. So what would we do with this patient? As most of the studies have shown, if you go according to the data, everyone goes on RAS inhibition first. These were when the studies were done without any guidelines available, where SGLT2 subsequently became first line. So as things stand right now in KDIGO guidelines, SGLT2 inhibitors are actually first line right next to RAS inhibitors. But we have done our practices when SGLT2 inhibitors came out earlier. So all of our patients were on RAS inhibitors. Then we see that this lady, if we start her on SGLT2 inhibitors, what would that do for her? It would definitely reduce her albuminuria. So you will have an agent which will control the albuminuria, because it has natriuresis effect and also osmotic diuresis because of the glycosuria effect. It would also control some congestive heart failure. There would be reduction in intravascular volume. Certainly that would lead to certain amounts of blood pressure control as well. So one agent, the addition of which will have effects on heart failure control, albuminuria control, perhaps even some type 2 diabetes control, and overall hypertension control. So that is what I mentioned, that because of these facts that have now been highlighted through various trials, if you look at the first line drug therapy in KDIGO guidelines, SGLT2 inhibitors are right there with RAS inhibition for the benefit of these patients, for long-term benefit of not only chronic kidney disease reduction, but also all-cause mortality, which was not seen by RAS inhibitors alone, which is a very important point. So SGLT2 inhibitors was the first class of drugs that we have put in the first line drug therapy for chronic kidney disease patients, which have reduced the total all-cause mortality for these patients, as well as reducing their heart events and cardiovascular disease-related hospitalizations. As Ms. Tan, this patient was elderly, one thing we do highlight to our colleagues is the use of loop diuretics. So it should not be underestimated that with the osmotic diuretic effect of SGLT2 inhibitors and also the natriuresis effect, there will be certain amount of intravascular volume depletion or contraction. So if these patients are on loop diuretics, they should be down titrated, especially in the elderly population, thereby reducing the risk of orthostatic hypotension and falls, which also seems to be a major risk factor that we need to reduce for our patients. One of the things that that we frequently get asked in the nephrology clinics by our primary care colleagues and other specialties is the risk of hyperkalemia. So as we know that SGLT2 inhibitors are complementary to RAS inhibition in reducing intraglomerular pressures. RAS inhibitors work on the efferent arteriole, SGLT2 inhibitors work on the afferent arterioles. So as we have seen hyperkalemia with RAS inhibition, there was concern that there would be hyperkalemia with SGLT2 inhibitors. Initial studies did show some hyperkalemia, but subsequently the risk of hyperkalemia in all later studies have been very, very minimal. And when we see it in our practical daily clinical care, hyperkalemia is almost very negligibly seen unless there is some major intravascular contraction and some other mechanism by which hyperkalemia is seen in these patients. In either case, the dose of RAS inhibition should not be down titrated, and SGLT2 inhibitors should be continued, because as many other studies have shown, that once you down titrate RAS inhibition or stop SGLT2 inhibitors, the risk, of course, of developing cardiovascular events, all-cause mortality, and CKD progression will go higher. So there are other strategies of dealing with hyperkalemia, including novel potassium binders and managing their intravascular volume, which are very effective in controlling hyperkalemia on the long run. And the incidence, overall incidence of or prevalence of hyperkalemia in this kind of CRM population is only about 4%. So it is not a major problem that we see. So in short, SGLT2 inhibitors should not be stopped, and management of hyperkalemia should be done to continue both of them to give the benefit of cardiovascular risk reduction and all-cause mortality for these patients. So this multifactorial management of a chronic kidney disease patients has a positive effect on the kidney outcomes, starting with blood pressure control, addition of RAS inhibitors, which we have been doing for over 2 decades now, and we were waiting for this third therapy, SGLT2 inhibitors, to reduce that residual risk, which was not treated by RAS inhibitors and blood pressure control alone. And so we have seen that residual risk reduced significantly with SGLT2 inhibitors, and now we can even add on MRAs for further risk reduction. This brings me to our second case, in which case we have a 34-year-old gentleman, Chinese ethnicity, has a blood pressure of 125/80, heart rate of 68, and no edema, lungs and heart insignificant exam. GFR is actually 78. I'm sorry, this is a typo. It's 78, and the urine protein to creatinine ratio is about 1.8 grams per day. So this is a classic case of IgA nephropathy, again very commonly seen in Singapore. It's a proteinuric state, and as many of the inclusion criteria for studies which have looked at SGLT2 inhibitors, there was this subgroup of glomerulonephritis patients who had proteinuric states which were included. So in this case, patient has a blood pressure which is reasonably well, could be better, but there's no edema, and significant amount of proteinuria with relatively preserved kidney function. So what would be our choices here? So we could definitely put this patient on RAS inhibitors, but it will significantly reduce the blood pressure. Another alternative now with SGLT2 inhibitors is that we can use SGLT2 inhibitors as a first-line therapy for proteinuric states such as IgA nephropathy. And this would reduce the proteinuria in diabetic patients and also in non-diabetic patients. So it is unrelated to their diabetes mellitus status. And not only would this reduce the CKD progression, but as I mentioned, would also have the added benefit of cardiovascular disease outcomes, hospitalizations, and all-cause mortality, the all-cause mortality part not being shown any benefit previously with RAS inhibition alone. My third and last case is a 68-year-old Malay patient with hypertension, hyperlipidemia, and a urine ACR when he presented to a GP visit of 85, which is in the moderate range. And the patient was referred to a nephrologist to see what to do. So initially, the management was that the patient was on irbesartan that was up titrated to give him the maximum benefit from RAS inhibition. GFR was quite preserved, and we saw that with the addition of the ARB, the urine ACR did drop a bit to 52. There was some decline in estimated GFR. Blood pressure became very low, and we could not further titrate ARB. So the ACR was still in the moderate range, 30 to 300. So here it was 52. And if we left the patient unattended like this is a classical case which will definitely progress on to chronic kidney disease 2, 3, 4, and eventually 5 with a trajectory which may take several years, but in the end would be one that would end up on dialysis due to the risk factors. So in this case, it was decided to put the patient on SGLT2 inhibitors, 10 milligrams of empagliflozin daily, and we saw that the urine ACR did decrease, and there were certain other titrations done to his empagliflozin to 25 milligrams, and the urine ACR dropped to about 3 milligrams per gram. The GFR also dropped, and in this case, the patient was counseled that this initial decline in GFR may make the blood test look bad, but overall, rate of progression of chronic kidney disease would be much lower over the next several years. There would be a cardiovascular risk reduction, all-cause hospitalization reduction, all-cause mortality reduction. And when we explain this to patients, usually we're able to see that these cases are basically able to be managed, and the patients would agree to being on these medications. So in summary, diabetes and hypertension are global. They are the main cause of kidney damage. Targeted early identification, early being key, offers a potential to substantially reduce the morbidity and mortality for chronic kidney disease and related complications, including increased incidence of cardiovascular disease, hyperlipidemia, anemia, and bone and mineral disease. Screening is for high-risk individuals and not for the general public. And the high-risk individuals are those with hypertension, diabetes, or cardiovascular disease, or certain demographics which are specific to each country. And SGLT2 inhibitors provide cardiorenal metabolic benefits like slowing down the eGFR decline, all-cause mortality, hospitalization, and so forth, which was not there alone with RAS inhibition previously. And with that, I thank you for your attention.